Thank you so much for having me. Thank you for the kind introduction. And I'm really grateful for the opportunity to discuss with you today what I think is a key topic in the management of patients with chronic lymphocytic leukemia that is actually often neglected to focus more on treatment choices. But I think that infections are key in the long-term management of patients. So the crucial question, I'd say, is, are all patients with CLL immune deficient? And that's a key question because actually by textbook, we consider all patients with CLL as having an impaired immunity, but there are different types of impairment. And on one hand, in the clinic, I have patients who never experience infections, while on the other hand, there are patients who, even without receiving any kind of treatment, are frequently bothered by severe infections like pneumonia, sepsis, and require hospitalization. So we have to acknowledge that CLL is shaping the immune system in order to advantage the disease. So it's causing an impairment at different levels. You probably all know that there are two different types of immunity. The innate immunity is actually, let's say, the first army we have against the infection, and it's activating promptly upon infection. But over time, we develop the so-called adaptive immunity, that is a more refined system that is specifically tackling in bacterial infection and viral infection. And you see that on one side, CLL is causing an impairment in innate immunity with complement deficiencies, in some cases mostly related with therapy, the occurrence of neutropenia. On the other side, we have an impaired adaptive immunity because we have low levels of immunoglobulins, the so-called hypogammaglobulinemia in a relevant proportion of patients, and T cells that are actually increased in the peripheral blood. If we measure T cells in the majority of patients with CLL, we find high levels of T cell. They are dysfunctional, so they are not playing their role in protecting the CLL patients from infections. So besides the disease per se, over time, we have additional factors that might worsen the occurrence, the infection risk, and may lead to the occurrence of infections. And in the past, we were very well aware of the toxicity in terms of higher risk of infections of chemoimmunotherapy, because some chemoimmunotherapeutic agents are like poisons for normal immune cells, including T cells. And so one of the key factor in the management of patients while receiving chemoimmunotherapy was to administer prophylactic anti-infective treatment. With novel targeted agents, I think the clinical trials prove that the risk of infection remains, but we have less solid guidelines in how to manage and prevent infection in patients receiving targeted agents. So this is just to show you that the increased risk for infection is related with the disease per se, and it's present even at the very low disease level, like the MBL stage. You know that there is, in the vast majority of patients with CLL, a sort of preneoplastic condition defined as monoclonal B-cell lymphocytosis, when you have very low levels of CLL-like B cells in the peripheral blood. And in this condition, where you do not have overt manifestations of the disease, patients are feeling well, they are completely asymptomatic, is finding during routine workup, you see still there is an increased risk of being hospitalized because of infections. So here on the right, the red curve is actually representing patients with monoclonal B-cell lymphocytosis. The green one is patient with CLL, and the black one is representing patients healthy control, let's say, so patients, individuals matched, age and gender matched. And you see that there is a higher risk of being hospitalized for infection even at the MBL stage. So during the follow-up phase, let's say the active monitoring phase, the risk of infection is actually still extremely relevant. Here in green you see that even without receiving treatment, the proportion of patients who develop infections is actually much higher than the proportion of patients who require treatment or died over observation. And the occurrence of infection here on the right is actually associated with a lower overall survival, so with a higher risk of dying because of the disease in terms due to infection causes. And as mentioned, actually treatment we administer to patients are increasing, in most cases, the risk of developing infection. This is just to show you that even novel targeted agents that are very effective in the preclinical works, they show to impair in some way the function of other immune cells. So the risk of infection is still there even in patients receiving novel targeted agent, provided that we are trying to get rid of chemoimmunotherapy, because chemotherapy, as mentioned, has a huge impact on the infection risk. So what can we do? Because we now acknowledge that there is an unmet need, that is the risk of infection in patients with CLL. So one task is to identify patients who are at higher risk of infection. And still we have some laboratory parameters, but they are not 100% reliable, meaning, as you see here, the presence of hypogammaglobulinemia, so low levels of immunoglobulins in the peripheral blood, is something we can check with blood drawing, is present in more than 60% of patients diagnosed with CLL at the time of diagnosis. And in patients carrying low immunoglobulin levels, the risk of infection is higher. But still, this marker is not 100% reliable, because we have also patients who are carrying hypoglobulinemia but never develop relevant infections. And it seems that the presence of hypogammaglobulinemia is also generally associated with more aggressive disease course. So a higher percentage of patients with hypogammaglobulinemia at diagnosis require treatment over observation. The next step, and there are studies ongoing, is try to use all the information we have about the patient characteristic, the disease biologies, laboratory values, in order to design an algorithm of artificial intelligence that identify patients who are at higher risk of infections. And this is a study that the Danish colleagues are currently running, where they use this algorithm, and as you see, the algorithm includes more than 228 features, so there is no way I can list them to you, but it's used to identify patients at higher risk of infection, and it's randomizing patients, so assigning one-to-one within a clinical trial to receive a treatment with venetoclax plus acalabrutinib, or to undergo active monitoring, in order to see that if active treatment is able to reduce the risk of infection by restoring the immune function. And we have actually preliminary data from clinical trials that suggest that with novel targeted agents, this might be the case, at least in a proportion of patients. So here you see, again, patients from the Nordic group clinical trials who received different type of treatment, acalabrutinib single agents, or the combination of ibrutinib plus venetoclax in treatment-naive setting or in the relapse refractory setting. As you can see on the right, some patients haven't had a previous history of infections. So the majority of them, even over treatment, they do not develop relevant infections requiring hospitalization or IV antibiotics. But among those who developed infection 1 year within the 12 months before starting treatment, there is a proportion of patients who start treatment and while of treatment improve the immune function, so do not develop infection complications. From a preclinical standpoint, I understand that this is a very complex picture, but just to show you that also with the combination of ibrutinib plus rituximab, we have some data suggesting that over time the immune function can improve so that patients responding to treatment with ibrutinib plus rituximab, where T cells are functional again, they do not develop infection anymore. And here you see on the right, actually, that the interaction between T cells and CLL cells is improving while on treatment, and this does not happen when patients are receiving fludarabine, cyclophosphamide, and rituximab, so chemoimmunotherapy. The other readout we can follow over time is by measuring in the blood the level of normal B cells. And these are the results of the Captivate study Bill led in the recent years, where you see that upon receiving treatment and then interrupting treatment because of remission achievement, the level of normal B cells is progressively increasing. So patients who are not receiving treatment after the 15 months of ibrutinib and then ibrutinib plus venetoclax, they have an improvement in the B cell, normal B cell level in the peripheral blood, together with other relevant population, including a decrease in these exhausted T cells that are dysfunctional, are not working properly against the infections and against the CLL cells. That is their job. More recently, an Italian colleague tried to define a predictive score in order to identify a diagnosis patients who are at higher risk of developing severe infection, meaning infections that require hospitalization and IV antibiotic treatment. And here you see that the most relevant factors that came out from this analysis are actually more or less the usual suspects. So age. We know that with aging, the immune system is per se impaired, and this might be even worse in patients with chronic lymphocytic leukemia. The immunoglobulin levels, including IgA, IgG, and IgM, and the stage of the disease, together with some disease features, including the unmutated immunoglobulin gene status. And those with a higher score have a much shorter time to first infection compared to those with low-risk disease. Here depicted in blue, the low-risk disease. It means it takes a longer time to develop an infection, while in red you see patients at higher risk of infection, and they develop an infection in the majority of cases and much earlier than patients without these risk factors. So what we can do to prevent infection? There should be something we can do nowadays together with the improvement of the preclinical and clinical research. So step one is vaccination. And we have to get our patients, and patients should get vaccinated as early as possible during disease course. Because as you see, the vaccine efficacy is decreasing over time. So if the patients get vaccinated at diagnosis, we have a higher chance that the vaccine is effective. If we vaccinate patients when the disease is active, so at the time of progression or during treatment phase, we decrease the chance of achieving a successful efficacy of the vaccination. So here you see, and I I'm sorry for the very small font, that there are at least 3 vaccines that are recommended, let's say, over the world. The vaccination against influenza, vaccination against pneumococcus, and recently vaccination against herpes zoster. I'm not going into COVID discussion because I know it's a lengthy discussion, and later on there are some updates from the work you have done recently, but I just want to point out that these 3 vaccines should be done as soon as possible during the disease course. And here you see also the most updated recommendation recently published in US. In green, vaccine that should be administered to all so-called immunocompromised patients. Recently, you see that there is an addition of the respiratory RSV, because in the last few years, the rate of severe infection increased in elderly people together with children, and especially in immunocompromised patients. But then basically, the only thing to keep in mind is that inactivated vaccine, live vaccines are actually contraindicated in patients with CLL, while all the others could be administered, and the decision is based also on the epidemiology of infection in some specific area. So we are doing research in order to improve the efficacy of vaccination. There are some strategies listed here. Some of them are already applied, others are under development. First point is, I think I already stressed enough, vaccinate early. There might be a different response based on the type of vaccine. So some vaccines may work better in patients with immune deficiencies. The addition of adjuvants may improve the efficacy of the vaccination. And as we learned with COVID, booster doses may also improve the response to vaccination. And here you see just one slide about COVID, because it was demonstrated since the beginning that patients with CLL have a lower antibody response to COVID vaccination. They reach lower antibody titers, and there might be differences if they are on active treatment or if they are in response of treatment. But what we recently show is that the serological response, we and other groups actually, the serological response improves if we administer booster doses, and there is anyhow a T-cell response that is not measured in the blood with standard tests because there aren't any, but it still occurs after the vaccination. So it's worth receiving booster doses even though the level of antibodies does not increase, because we are, let's say, sending a reminder to the T-cell compartment of the immunity. About prophylaxis, I'm just discussing for a few minutes because there is no consensus with the novel targeted agents. I mean, there was consensus with chemoimmunotherapy. Now you see that basically the NCCN guidelines suggest that the use of prophylaxis should be tailored according to the specific patient profile. So if there are additional risk factors besides the fact of being on treatment on, for example, BTK inhibitor, the physician should prescribe prophylaxis. Otherwise, it's very difficult, and basically every physician and every site follows a different policy. While there are indications to administer prophylaxis in patients receiving anti-CD20 monoclonal antibodies. So last but not least, the use of immunoglobulin replacement. As you can see from this slide, the study on immunoglobulin replacement were done a long time ago. So the problem with this study is that they are outdated in terms also of treatment types and treatment outcomes. But they never demonstrated a clear improvement in outcome in terms of mortality in patients receiving immunoglobulin replacement compared to those without immunoglobulin replacement, while they showed a benefit in those experiencing major infections in reducing the number of infection episodes, thus improving generally the quality of life of the patients. There are two, let's say, route of administration. One is subcutaneous, the other one is IV. And recent studies suggested that not only the subcutaneous route is more convenient because it requires less access to the hospital, a patient can self-administer the sub-Q immunoglobulin, but it might be also better in terms of infection control. And with that, I just want to conclude that infections are relevant in patients with CLL because they are causing morbidity and mortality in this group of patients, and their prevention and control remain an unmet clinical need. So the three tools we have available are vaccination, infection prophylaxis, and IG replacement, and we should use them in an effective and wise way in order to prevent infection. And definitely this is an area where we need collaborative research in order to better understand how to improve the management and the outcome of our patients. And with that, I thank you for your attention, and I want to thank actually the people I'm working with at San Raffaele, and in particular Paolo Ghia, who is doing a lot of research on this topic in order to improve the outcome of the patients.